Here we go. All right. Okay. All right. So I'm gonna actually, I beg your pardon. First gonna introduce our team. So I'm Kari Rabi. I'm the Chief Medical Officer. I'm a family practice and addiction medicine physician here at the Native American Community Clinic. Dr. Myra, would you introduce yourself?
Bonjour, I'm Laurel Myra. I'm the Director of Behavioral Health here, and I'm originally from Red Lake. Welcome.
Thank you. And Michelle?
Hi, everybody. I'm Michelle Corcoran. I'm the MAT Nurse Manager here at NAC.
Thank you. And Beth?
Hi, I'm Beth Ryan, and I'm the Project ECHO Coordinator.
And then Renee, you already introduced yourself. Donna, would you mind introducing yourself?
Hello, I'm Donna LaChapelle, one of the elders here at NAC. Welcome, everybody.
Miigwech. So here we go. Let's go back to sharing. Okay, so this is the Midwest Tribal Echo. We've already had the prayer and land acknowledgement, Miigwech. Renee, and I'm going to be doing the introductions and agenda. And then I'll be doing the Zoom guidelines. Michelle's going to be doing our announcements. And then I'll be doing the didactic with Donna LaChapelle, harm reduction in pregnancy. I think that Michelle's actually going to be doing our case presentation today, and then we'll be closing. I think we're all very familiar with Zoom these days. However, please introduce yourself in the chat function. That also allows us to get you access to the CME or CEU's name, title, organization, email. You can also right click on your name on the screen and rename yourself so we know who you are. Please turn your camera on so we can see you. It just makes for a better discussion, and it's nice to see everybody who's here. Please mute your microphone if you're not speaking. We may mute your microphone for you if there's background noise, or just so that we can hear everybody more clearly. You can use the chat or hand raise function if you would like to speak, or you'd like to ask a question. And then, as always, no protected health information. Michelle, could you please do the announcements?
Absolutely. So we meet every month on the first and the third Wednesday at noon. Feel free to eat your lunch, drink your coffee, whatever you need to do during that time. Some of our upcoming sessions. So for those of you who joined us for the Indigenous Health Toolkit Part 1, we're going to be doing Part 2. That's with Dr. Melissa Lewis. And then in March on the 3rd, we're going to be doing Intercultural Development Inventory. So learning more about that with Lisa Shefke, who is a health equity specialist. And then for the continuing education credit, so my understanding is you don't get a certificate after each session. However, as long as you tell us who you are, where you're from, and your email address, you'll get a survey. You complete that survey, and then a couple times a year, you'll get emailed to you kind of all your credits that you've attended. So, and that's about it.
And that brings us to our presentation, harm reduction in pregnancy. So if any of you were I did this at an Echo at Hennepin last week. So just so you know, this is a very similar, if not the same, presentation with maybe slightly different emphasis today. And then also I've talked about harm reduction on this Echo before, but I think it's worth revisiting in the context of pregnancy. I'm joined by Donna, who's going to be helping me with that. So our objectives are to identify the features of harm reduction in relation to pregnancy, apply cultural humility when giving care to pregnant women, to formulate an approach for treating pregnant women with substance use disorder, regardless of their readiness to be sober. And of course, we are a Native American community clinic. We're a federally qualified health center. Our patients are around 87% identify as Native American, and we serve about 4,500 patients annually. So our patients experience significant barriers to receiving adequate prenatal care. There's shame, fear, and stigma that comes with substance use disorder, and then also being pregnant. There's a lot of judgment of women who are chemically dependent when they're pregnant. And that can in and of itself be a huge barrier to seeking prenatal care. Additionally, there's a systemic racism that our patients experience that leads to a lack of trust in healthcare providers and systems. Our patients experience very high out-of-home placement rates. Mandated reporter laws that criminalize drug use make it hard for them to trust their healthcare providers and to help them during the pregnancy, and the fact that we have to report them. There's a lack of understanding for some medical providers of substance use as a chronic condition versus a moral failing. There's a lack of culturally competent care for our patients and community. There's a lack of trauma-informed care. Our patients have a high rates of historical trauma that they've experienced in their lives, as well as personal trauma. And then our patients experience high health disparities with high relative risk scores, meaning that they're more likely to have bad health outcomes, including death, than the rest of the U.S. population and the Minnesota population. I also want to make sure that we recognize social determinants of health and lack of resources are also barriers to prenatal care. Things like lack of insurance, lack of transportation, lack of food, shelter, and this all feeds into the concept of a hierarchy of needs. People who are trying to get their basic needs met have a difficult time accessing healthcare. In some studies have shown that about 27 to 51% of Native American women are not receiving adequate care prenatally. So by comparison, the next group with a high rate of lack of adequate care are African American women, and their rate are something like 10%. And then that's important because women who receive inadequate prenatal care are experience higher infant mortality rates. Mandated reporting is an important thing to discuss. Studies have shown that women who misuse drugs during pregnancy do not trust their healthcare providers to protect them if they disclose their substance use, and therefore they tend to avoid or emotionally disengage from prenatal care. And then when you look at babies who are experiencing neonatal abstinence syndrome, 34% of those babies in Minnesota receive inadequate or no prenatal care versus only 14% of babies for non-NAS births. So I think it's important to recognize, I just don't want to go through all the slides in depth. I think it's important to recognize that Minnesota is one of a minority states that really in their legislation criminalizes chemical use for pregnant women. And I leave the slide on there for you to refer to, but I think that is something that could be addressed with legislative changes. Native American pregnant women have a high rate of opioid use disorder. About 1 in 10 pregnant women are suffering from opioid use disorder, and Native American babies have rates of NAS that are 8 times higher. Native American children are 17 times more likely than white children to be removed from their home as a result of parental drug abuse. This correlates with other disparities by race in Minnesota, and I think it's important to recognize that while Minnesota has one of the lower overdose rates in the country, it has the highest race disparity of all of the states as far as overdose goes. And this is it's very clear by this data. You can see that the rates for Native Americans versus white people in terms of overdose mortality. So we've covered, Dr. Jones covered this when she gave her presentation, but I just thought it would be worth revisiting that opioids do have effects on pregnancy, including the direct effects of withdrawals and micro withdrawals, and then effects that are related more to chaotic use and comorbidities, and then risks associated with opioid use like infections, injuries, and overdose. So we've talked about harm reduction before, and it is about meeting patients where they're at. And harm reduction, the definition is to reduce the negative effects of certain behaviors while still promoting an individual's autonomous choices and their well-being and the choices around their health. And at this quote by Johann Hari is relevant at this to say yet again, the opposite of addiction is not sobriety. The opposite of addiction is connection. And I think the important part of this is, as we're formulating an approach to patients who are struggling with chemical dependency, recognizing that making those connections within the community and for our patients allows them to access help more effectively than if we weren't focused on the connection. So principles of harm reduction, humanism, pragmatism, and individualism. Humanism is about not stigmatizing patients and not stigmatizing chemical dependency and seeing them as individuals with individual choices. It's also within individualism, I think we have to talk about cultural humility, recognizing that as providers, especially, that we have one worldview, but the patient's worldview is really what centers them, and to respect their autonomy and respect the choices that they make regarding their healthcare and support them in their goals. Incrementalism is another one I like to talk about because we need to recognize small successes. If a patient's able to be sober for 2 weeks, that's a success. If a patient has an episode of use and returns and reconnects, that's a success, versus like looking at it as an all or nothing thing. And unconditional positive regard, I think, is also a very important thing when a patient comes into the clinic when a pregnant woman comes into the clinic. I see them as a mother who's very excited about her pregnancy and excited to be pregnant, and those are the conversations I have with that woman, regardless of whether they're using chemicals or not. So it's important to see substance use disorders as a chronic disease versus a moral failing. Nobody chooses to be addicted to drugs, just like nobody chooses to develop heart disease. Individuals do choose to eat a hamburger, or individuals can choose to use drugs, but they do not choose to become addicted to drugs, and they do not choose to develop heart disease. Both addiction and chronic disease change biology. It changes the way our bodies work. And then relapse is common both in addiction and in other complex chronic diseases. We wouldn't cut a patient off of insulin because their diabetes was out of control and they weren't taking it as often as we think they should. Just likewise, we try and maintain a connection and a relationship with our patients with chemical dependency after a relapse or episode of use, and we do not terminate their access to the treatments and medications that will help them. So specifically in relation to pregnancy, our approach to pregnant women who have chemical dependency is to try and reduce stigma and provide support to create the connection with women so they feel comfortable coming in the door and developing a relationship with us and trusting them with the care of themselves and their child. We at our clinic, we do not do routine urine toxicology screens. We feel that it's a woman chooses to disclose to us whether they're using or not. And we try and provide them with as much information on mandated reporting and what that means and how to access help before, so that they can make an informed decision before they disclose to us their use. And then as far as mandated reporting, Hennepin has Project Child, which is a little less active than it used to be, but the idea is that if we can get a woman connected to resources before 32 weeks, that they don't always get automatically referred to CPS, and these are actually problems we're actively trying to work on in terms of ensuring that CPS does not get involved unless it's a very last resort. We try to offer support to women in navigating their concerns around CPS and mandated reporting, and we try and let them understand that we're on the same side of the problem with them. Our goal is that they go home with the baby when they're in the hospital. The baby comes home with them, and that the best person for their baby to be with is them. So I'm going to ask Donna to step in.
Yeah, I asked Dr. Ravi to bring in the land for us. So this is a road to the Black Hills, the Badlands. Beyond the Badlands is the Black Hills. But this is a sacred site in South Dakota. And if you ever have a chance to visit, it would be a good place to be in awe of the land. So today, when I was thinking about the land, I like what Renee had to share in her prayer that, you know, if you can imagine pre-contact, that this whole North American continent was filled with an estimated 18 million native people. So their blood and their bones are on the land. And we are the land. You know, that's our spirituality. We are not owners of the land. We're one with the relationship and the spirit of the land. So this is our first mother, our spiritual mother. And I'm going to speak about the 7 grandfather teachings and the spiritual support that we have for our clients. But when I was thinking about, you know, our young women who are coming in addicted to opiates and needing prenatal care, I was thinking about women's health, that we need to educate them even before they get pregnant. And that could be a goal that we set for ourselves. But as caretakers and doctors and nurses, we have a responsibility to reach them. And I like, you know, some of the information that the most important thing is the connection that we make with one another. So this is a spiritual principle that most tribes across the United States practice. And when you think about how do we incorporate these teachings into our own lives, I believe that these principles are universal, like universal laws for across the world. And everybody has a responsibility to be first a human being. And with these teachings, we can respect one another. And even before we see a patient, that we come in with that information that I'm going to be a good relative. Because you don't know if you're facing, who are you facing? You know, another spiritual human being, you know. We all have spirits. And so if we greet somebody on that level, we made the connection. And things are guaranteed to work for the best interest of the client-centered care. So we have to take our own assessment of where we stand without judgment. So these teachings are values that we can own for our own lives to be a better human being. And I looked on YouTube, you know, over the weekend and last night, and there's so many programs that you could watch and get some more information, because we could spend some time on each one of these and how do we address it in our own lives. And even in our settings, you know, I was thinking about how do we look as a clinic when our people come in, and if we post these teachings and the meanings, the interpretations behind them, and how to live together in a community, that would be another tool that we could use. And I like, you know, what the last session that we had with the toolkit, you know, we can incorporate all of these to help us as caregivers, even before we see a patient. You know, I've worked with young women who have been pregnant with their mothers and the women themselves. And, you know, the addiction is, I call it the beast, because sometimes it gets a hold of you and your psyche, and you can't get away from it. You think you need it for your survival, so you chase it. And that's the crime, the tragedy in our community, that some young women will not care about themselves or their baby, that they'll run to the drug, and sometimes they survive and sometimes they don't. But just last year, there was a young mother, and her grandmother cried every day for her and tried to get everybody around. She was on the streets and she was addicted to heroin. She got the police involved, but none of us could do anything for her. But she delivered a healthy baby, and it was a blessing. But the grandmother is trying to get custody now, and we can support the grandmother and help her with all that she needs. So we don't understand the bigger picture of all the things that happen in our lives. And I have to just trust the process of a Creator, and knowing that that next generation is coming, and we have to be prepared for them. So we extend that helping hand and doing the best work that we can do. So next. So what I do here and what Renee does, we provide spiritual support. So when I think about, the future and where we're going and how to implement care for our young women and our relatives who are addicted, is that we need to build that connection early on. So we have work ahead of us. But it can be done, it's not impossible. So we sit with our relatives and we pray together, we use our medicines, the sage, tobacco, cedar, and sweetgrass, and we visit and we connect. And that's the most important thing that I've learned in this healing process, is that we need to connect, not judge, just accept this other human being as a relative, because we don't want to harm anybody. Harm reduction. We don't want to do harm to anybody. We don't want to cause trauma. We want to accept with compassion and kindness and open the door. Because the truth of it is that we are all related, no matter what our skin color is or where we come from. So Dr. Myra, do you have a question?
No, I was just responding to some questions that are coming up in the chat about mandated reporting.
Yeah.
And like when you have to report to CPS, and then another resource of Bright Beginnings, a culturally specific program like Project Child, an alternative that people can do as well.
Yeah, thank you. Yeah, we'll have time for questions. I think we're close to the end. Yeah. So, the basic needs, it's most important before we can even address anything, is in any situation that we have, to make sure that they have food and shelter. And then we can begin to address, what comes after that. But Maslow's hierarchy, that was taken from the Blackfeet tribe, that first we addressed the need for safety, shelter, and we provide that at the clinic. And some of us have been trained in trauma-informed care and our own understanding of cultural humility, you know, that there are other worldviews and that it doesn't have to be one way or only. We can be open to receive another community, you know. We don't have to put any of our own barriers up. If we just think about our own hearts and our own families, how much we love them, we want to keep that in our hearts all times. And I know that in clinics and hospital settings, we get stressed easily, and the demands on our time makes us crazy. So we have to pause and we have to regroup ourselves before we walk into that room and meet another young woman, young man, anybody who needs our help. So we take a breath and we go in with our best face, our best practice to make that connection. So I thank you.
Make which, thank you.
Yeah.
So, I talked a little bit, thank Miigwech very much, Donna. We talked about this thing about urine toxicology is an important issue because, and I put the slide in here, I kind of touched on it already, but just if you are going to use urine toxicology during pregnancy, it's important to recognize the consequences of using urine toxicology to the patient, and that false positives are possible. It's just a moment in time. It doesn't tell you whether it doesn't always catch chemical use. And then it's not always correct. So as I said, in our clinic, we don't use urine toxicology during pregnancy, and unless somebody is on Suboxone. Also want to talk about harm reduction services. We provide medication-assisted treatment through buprenorphine, and we use a medication first policy, which means that they can access medication at their first visit. They don't have to go through any steps like do a Rule 25 or anything like that, or before they can have access to the medication. We also provide syringe services, including rigs, Narcan education and distribution, and we make sure that we have flexibility in our schedule so we can see patients as walk-ins for concerns related to substance abuse or any concerns that the patient might have. So we've covered these before. These are the different medical treatment options. The recommended treatment during pregnancy for opioid use disorder is methadone or buprenorphine. When a patient comes in and expresses interest in getting help with chemical dependency, we review their use and history and assess and educate them regarding safer use, make sure that they have that information. Talking about safer use lets people know that you want to help them regardless of where they're at, and if they choose to continue using, I still consider myself their provider, and they can still come and access services regardless of whether or not they're pursuing sobriety or what else is going on with them. We always ask if they've tried buprenorphine before and how it worked for them. I ask them how long they expect to be on medication. This is a good way to kind of figure out what some of these expectations are, and also like whether if they feel any stigma around being on buprenorphine or Suboxone. There's a lot of misinformation in the community around Suboxone that it's just another drug, and patients themselves sometimes just don't want to be on a medication for the chemical use disorder. So it's important to have that conversation. If there's opportunity for education and giving them more information, this is a good time to talk to them about that. And to also talk to them about, some women want to be on it for pregnancy and get off right afterwards. And I always talk about the fourth trimester, baby's first years are all time of high stress, and it's good to have the assistance with buprenorphine or other programming at that time as well. And then as I mentioned, we talk about CPS and mandated reporting, trying to make sure that they have all the information they need to make informed choices for themselves in their pregnancy. I check on who's around them and whether they're supportive or using. It's also like who might, like partners a lot of times don't want the women to be on buprenorphine. They just because of, in my opinion, somewhat of a lack of information about how buprenorphine works and what it means for the pregnancy. So we try and talk to them about that. And then I'll say here again that you know, being on buprenorphine or methadone is it results in the lowest rates of neonatal abstinence syndrome, because women who try to go to get off of buprenorphine are far more likely to relapse and have a baby born exposed to non-legal opioids. We also check, of course, if they have housing and basic resources. We assess for sexual trafficking, sex work, and see if patients need resources around that. Ask them about their safety and their mental health. We've covered this before, but buprenorphine and methadone have a lot of benefits during pregnancy, and I've listed these out here. So NAC, when we do an OB and MAT intake, a patient goes through an initial screening appointment where we give them a lot of information around chemical use, safer use services, including Narcan and needles. We have them meet with potentially a patient advocate, integrated therapist, a chemical dependency coordinator. We do their initial labs, and they get initial Suboxone prescription. Usually we see them back within 3 to 4 days to see how they're doing on the buprenorphine, and they get their further OB intake at that time. And we schedule the OB physical. And then for the MAT follow-up, we initially see them weekly. And then once they're stable, and for us stable means they're attending their appointments, not having consistent use, the Suboxone is showing up in their system, then we might, and after about a month, we might roll that out to more every 2 weeks. And then again, depending on where they're at with their sobriety, we roll that out to monthly. And then the prenatal schedule is the opposite. So with prenatal visits, it's every 4 weeks until 28 weeks, and every 2 weeks until 32 weeks, and then every week. So that tends to intersect at some point. So we kind of explain all that to the patient so that they can manage their expectations around follow-up. We also, of course, talk to them about daily dosing. To be honest, we don't a lot of times do daily dosing during pregnancy because we want to make sure that patients have access to the medications. And that's a little bit of a dilemma for us, because our experience also tells us that for some patients who are struggling with chaotic use, the structure of a dosing program is very helpful to them. And having a Rule 25 assessment is a good way to sort of assess that and sort of try and help patients through the decision as to what kind of treatment they're gonna go to, if they're gonna go to treatment, and whether the inpatient or outpatient treatment would work for them. So that's another way to sort of provide people with structure if they're struggling. Also, we make sure that they have access and know about the elder in residence, behavioral health, Project Child. We try and refer them to doulas. We haven't been that successful in doing doula referrals, but continue to work on sort of better ways to connect patients with doulas. And we're talking about maybe bringing doulas into the clinic so that the patients have an opportunity to meet them and feel whether they'd be comfortable with them. Also, we make sure they have access to peer recovery, dental services, and then medical specialties as needed. So again, just during pregnancy, my experience is that patients frequently at some point want to decrease their dose. Again, they're trying to reduce, in their minds, they're trying to reduce the possibility that their child will go through withdrawal when they're born. The neonatal abstinence syndrome, again, having conversations and educating them around the fact that neonatal abstinence syndrome does not increase in severity with the increased dose. And again, that the safest thing for them and the baby is to be on a stable dose of buprenorphine with which they're not having cravings or withdrawal. Sometimes one might need to do split dosing during pregnancy. We've experienced that for some patients, being on a once-a-day dose actually is, even during pregnancy, is better than split dosing. They seem to hit a peak, and then that seems to work better than a divided dose. But we work with each individual patient according to where they're at and what works for them. It's really important to set expectations around labor and delivery. we have relationships with the hospitals in the area, and we talk to the patients about the hospitals and experiences at the hospitals, where they want to go. Once they've chosen a hospital, we make sure that the hospital knows the patient is coming and knows what the plan is for them, especially around pain management. And our expectation is patients will continue to be on the buprenorphine as prescribed throughout labor and delivery. And if they have a C-section, we generally recommend that they use pain medications on top of the Suboxone. We talk about, making sure they get an epidural, and then as far as the neonatal abstinence syndrome, we talk about eat, sleep, and console, skin to skin contact, and sort of talk to them about what the hospital policies around that are, and that in and of itself is like such an important thing in terms of empowering women to do what's good for their child, and they feel that they can. It helps them to feel more empowered in being a part of their care plan and ensuring their children's comfort. And this just to be very clear, breastfeeding is recommended for mothers on Suboxone and Methadone. There is misinformation out there, and that women should not breastfeed when they're on Suboxone. We run into neonatal nurses who feel this. It decreases the severity of the neonatal abstinence syndrome. It sort of dovetails really nicely in with eat, sleep, and console. Shorter hospital stay, less need for morphine, all of those things. Breastfeeding is not recommended for women who continue to use illicit drugs, women who have HIV infection, and if they have hepatitis C, if they have bleeding nipples. But women can be counseled through this, and you can talk to them about like if they have a relapse, to pump and dump, or just so that they are empowered to make the best decision for themselves and their child. I'm not going to go through this, but this is the Northern New England Quality Improvement Network breastfeeding recommendations and guiding principles. And what I like about this is they really emphasize communication with the mother, and including the mother in the decision process in terms of their decision to breastfeed. Postpartum, it's important that you maintain continued care coordination support. Make sure that they have access to contraception if that's what they want. Make sure they have a Narcan prescription and a relapse plan. Access to parenting support groups is a very important piece. And Bright Futures for example, is a good peer group that provides women's ongoing support after baby is born. And then also educating them on safe use in parenting, like what constitutes a child protection support report. So to make sure that they understand that if they do choose to use, to make sure that they have another adult that is not using to take care of the baby, and that they don't leave any paraphernalia around. And of course, around the breastfeeding, not to breastfeed if they're using illicit substances. And then always remembering to talk about the difficult things. And I always say, it's not important that you get even an honest answer around the stuff, but I think it's important that a woman hears that you're asking them about survival, sex, violence, and then ongoing drug use, and that you're projecting a non-judging attitude when you ask about those things, so that they don't feeling that you're going to terminate your relationship with them if they answer positive, for example, to ongoing chemical use. Okay, so that is the end of the presentation. I think buprenorphine is a preferred treatment along with methadone for opioid use disorder, and harm reduction is an effective method to support pregnant women's choices to be abstinent from illicit drugs. Thank you. Any questions? I'm just gonna.
Thank you, Dr. Robbie. There are some questions that came up in the chat. There's a question about recommendations around breastfeeding and HIV. Do you have any recommendations for that?
There is a possibility that HIV could be transmitted through breast milk, so it is not recommended for HIV positive women.
What if somebody is undetectable? Does that change?
Then I would say that would be safe.
Okay.
I have not specifically looked at that, but so I guess I should say that I should make that caveat, but yes.
Yeah, I guess that would make sense.
Yeah.
Dr. Grant also has a question about when you refer when do you refer someone to CPS or ICWA?
Okay, so with mandated reporting, referral, it's mandated by law that a patient who is using illicit substance, who discloses that they're using, or who has a positive urine toxicology screen, you have to report them to Child Protection or ICWA. In Hennepin County, if they're before 34 weeks pregnant, though sometimes they say 34 weeks, but really the thing is that they should be connected to treatment before 34 weeks. So it functionally turns out to be 32 weeks. If a woman can get sort of connected to services and establish some stability and sobriety, then they don't need to be reported to CPS. And so you start with a referral to Project Child, and Project Child connects them with resources, and that can even though it is a part of CPS, and that can keep a woman away from a child protection report. We're finding that the engagement with Project Child is not very high at this time. It used to be higher, and there used to be a lot more callbacks, a lot more connections. So just be aware of that. And I think that there's room for, as a provider, to really advocate on the part of the patient in terms of reaching out to Project Child and helping the patient to make the call with them, so that to make sure they get connected and are less likely to get reported to CPS, because they turn the case over at 36 weeks. If there's no 34 weeks, they turn the case over to CPS. Project Child does. Does that answer your question, Dr. Grant?
I added a bit of a follow-up to that. So how then does ICWA get involved if a CPS case then does get opened? How does the mom or family get support from ICWA?
My understanding is that if the parent is tribally registered, then ICWA needs to get involved. They need to get ICWA. They go to ICWA instead of CPS. Dr. Meyer, is that your understanding?
Yeah, so right away when the child is identified as Native American, they'll actually get a case manager that's an ICWA case manager as opposed to a CPS case manager. And then as far as like tribal involvement, it's really based on the tribe's specific policies around involvement and availability of funds to support additional legal support. But we were talking in the chat about Bright Beginnings. So Bright Beginnings is also has ICWA case managers. So that is an alternative that you can use. And the women who've been working there have been working there for 20 some years and are able to really understand tribal law and laws around ICWA and how to support families.
Thank you. Dr. Grant, did you have something else to say? Sorry.
Great call. I was actually curious about postpartum. I know you and I have personally talked just about the antenatal, the antepartum period. I'm curious, when and how do you screen, or when or if do you refer in the postpartum period? Because I think it's a much more gray area.
Yeah.
Like you were saying, it's like
yes.
How to make sure that, yeah.
So my approach to that is that CPS, but mandated reporting to CPS is if the child is in danger, and in terms of chemical use, it's if a person is caring for a child by themselves while they're under the influence of illicit substances, or if there's drug paraphernalia that the child can have access to. So so I normally wouldn't know about the drug paraphernalia, for example, because I'm not in a person's home, right? I have had, for example, somebody come in where a child got into somebody's purse, and they told me that the child got into the purse, and then I was mandated to report that, but that's not something I normally see. And then if a woman were to tell me that she was using and there was no other adult around, then I would need to do a CPS referral. But otherwise, use in and of itself is not a reason for a CPS referral. if something came to my attention that I felt that the child was in danger, then I would of course be mandated to do a CPS report. I had a patient some years ago with that was using benzos, but her partner was there all the time, and I talked to both of them, and he's like, I'm there, I'm always watching the baby, you know, and that was not a mandate. That was not a mandated report. And I think that there is a misunderstanding about that in the medical, like for providers. I think providers feel like if a mom uses, they have to report, and that is not the case.
And I think too, there, one of the conversations I find myself in a lot of times with providers, both medical and behavioral health, is just really clarifying what is supportive, because I think there a lot of programs, social work programs and things like that, a lot of times teach people that the best thing to do is intervene with child protection because they're gaining access to resources. However, that's not the case. In Minnesota, there's a really high disproportionate rate of screening with Native women in particular to identify substances. So white women who are using drugs are not being identified. It's the Native women. That's the reason for that disproportionate rate. You know, there's really poor outcomes in the state of Minnesota for Native children. They're a lot of times removed at much higher rates. They stay in child protection shelter or foster care much longer, and they're much less likely to be reunified with their families as well.
And it has been demonstrated that children do not do well in foster care. It's not a safe environment for children a lot of times. And I you know, in my practice, I see the trauma that children experience in foster care and have experienced, and I see in adults who've been through the foster care system, and also in children. So it's like there's this idea that if by doing the CPS report, you're going to provide a safer environment for the child, and that is just not the case. And also, I think there's a perspective that a person who's using chemicals cannot take good care of a child, and there are cases with chaotic use where that may be true, but I have seen so many moms who have taken really good and conscientious care of their children, and have known when their use has gotten to the point where they need to get somebody else involved, you know, get a relative involved. And I can think of, like, in my mind right now, I can think of 3 specific cases of women with ongoing use who have just taken wonderful care of their children. So there's just a lot of assumptions being made. And I think it really speaks to the competency of providers in terms of being able to navigate navigate these issues without just doing a knee jerk, like, I don't know what to do, and so I need to guarantee the safety of this child, and so I'm going to do this referral. And that's where the harm reduction conversation comes in as well, because they're looking at the most immediate boundaries they can place on the situation without looking at the wider harm that's happening to the child when they make that child protection referral. If that makes, yeah. So that's my soapbox for sure, but yeah.
So this is Sarah McCumber. Can I ask I'm going to ask a question out of naivete. So it sounds like you do a really good job in your clinic of not doing the urine drug screens. When women go to the hospital, how do you make sure that approach continues? Because
it's not gonna. I have no control over what happens in the hospital, and there's a difference as well between like hospitals have protocols. Like if the law says if you suspect a woman of drug use, you have to do urine tox. So every hospital has a policy and a protocol around when they test.
Okay.
And I think hospitals are moving to somewhat more equitable, like they're not just testing.
Okay.
But the problem is when they have language in their policies and procedures that say things like, you know, like if there's, you know, preeclampsia, they'll list the conditions and then they'll say, or the provider suspects it, and that or the provider suspects it allows bias to come in. And that's, I don't know if anybody was present for Lisa Sheffy's talk on bias and policies and procedures, but when you have that subjective language in there,
Mhm.
that's where you allow individual bias to creep in and who gets drug tested, who doesn't. So we definitely try and educate our patients on
Good.
that and what to expect. And the other thing we educate our patients on is marijuana. Marijuana is not a mandated report for a primary care provider. The law expects that a primary care provider is going to educate their patient on abstaining from marijuana and alcohol, actually, which is the most toxic substance to a pregnancy. You don't have, that's not a mandated report. But when they get to the hospital, because it's not the primary care, that is a mandated report. So preparing women as well for that if they go to the hospital, and I've had a hospital where they've looked back at the records and found a positive marijuana on a Utox for a patient of mine, and say like at 32 weeks, and then they call social services because they see it in their record. So another reason that informed our decision to stop doing urine toxicology screens, because I can't control what happens to the information once it's out there. So we don't test for marijuana anymore on our urine toxicologies for any of our Suboxone patients, because we can't control what happens to that information when it gets into the wider system. I hope that answers your question.
It did. Thank you.
Thank you.
China is asking about alcohol use postpartum, and if that is also not a mandated report. Does that follow the same guidelines as you indicated? Like, as long as somebody's watching the child, and they're not under the influence as the only caregiver.
It would be the same, China. That it would be the same thing, and I think, of course, alcohol is far more acceptable. But it's the same, I think, and it would be the same. Can a patient refuse to have Detox? No, I think they can get a court order to, I don't know if they can court order the patient to be Detox, but they could do the meconium testing. Dr. Gray, and you're more in the hospital system. Can they force a woman to have a urine toxicology in the hospital? So you're on mute, I'm sorry.
And just to provide a little more context to the question, I'm just thinking about respecting patient autonomy, that we have to get informed consent when we do any kind of procedure or test.
Yes, they can get a court order though, and my understanding is that they're less likely, if the woman refuses it, then they can, it is mandated that they can do it on the child, but I'm not sure if they can do it for the mom. Do you know, Dr. Grant?
I don't think so.
Yeah, I think
there's no criminal action that's taken place, so there's no legal force for that. I think there's a gray area though in terms of like meconium.
Yeah, they do with meconium.
So that's like, if it's part of a procedure and it's there, then can you take it? Because you're not really actually asking for a sample to be provided. It's there during the pregnancy. So I think that's oftentimes a question mark. Similarly, depending on how facilities do it, I believe that there's a variation in notification to patients, particularly to the moms, about umbilical cord testing. So you can also take a tissue sample from the umbilical cord and use that for drug testing. And there's a whole variety of different issues with that in terms of what people want to use and keep for their own, and how people identify with that. But many places just identify that as just tissue to be discarded as part of the birth process. And so oftentimes you can take a section of that. So it depends on the hospital facilities, what their policies around that.
Mm-hmm. Yep. Thank you.
I see that it's 1 o'clock. I'm
What?
sure we could all, maybe we should start making these longer.
Nope. Any other last comments before we end for the day?
Hey, Britt here. Yeah, I think that a continuing series and discussions like this, especially when it comes to all these nuances, when it comes to, pardon me, pregnancy, substance use, how we navigate the intersections of providing harm reduction and compassionate care to patients, during and throughout their pregnancies, but also knowing that there are certain laws that we need to follow, and also knowing that a lot of these laws about mandated reporting are really steeped in colonialism and are damaging to BIPOC women, and how we can work with the systems that we have before we have to involve CPS, because yeah, like it is damaging and it's very traumatizing, and it's a conversation I want to have continue, because I've worked with several patients who they get pregnant and their entire history of prior to this pregnancy of previous pregnancies is those children have all been removed permanent. It's all permanent removal, and or miscarriage, and it gets a little depressing because you're like, there's not going to be a happy ending to this, and damn it. So yeah, I would definitely think that these are really good and helpful conversations, and it can help really shape our work in a more person-centered way and with cultural humility.
Language, Britt, thank you.
Yeah, thank you for that. And you guys are welcome to reach out to us to outside of these sessions if you have questions or would like some guidance on anything.
Yes, and I'm just trying to remind myself, our next talk is on the Digital Health Toolkit, Part 2 with Melissa Lewis. So I hope you all can join us. We had a really good discussion last time, and that was a request for follow-up, and she was willing to do it. So we're very excited about that. And that will be on, do you remember the date?
17th, I
17th.
believe, something like that.
So we'll look forward to seeing you all then. Miigwech, thank you very much. And Beth, could you leave this open for the team? And then goodbye, everybody.
Bye-bye.